Conference recording started.
Well, welcome everyone. This is Kim Workmeister. I'm the Clinical Improvement Educator for the CalHEN and for HQI, and I am thrilled that you're all here today for our webinar on optimizing VTE prophylaxis. And you're really in for a treat today because I have to tell you, our speaker, Dr. Ian Jenkins, is wonderful. I've heard him, I've had the opportunity to hear him speak many, many times in the last few years, and he's truly one of the utmost authorities on this topic area, and it just has just a wealth of information to share, very practical, down to earth. You're going to be very glad that you joined us today. But you know, just so we can back up a little bit and talk about why it is that we even chose this topic for our webinar today. You know, in the last couple of months of this HEN 2.0 sprint that we're in, we really want to highlight some of the practical improvement ideas for many of the topic areas. And honestly, VTE is one of the topics where we're not yet meeting that goal of a 40% improvement. And in a moment, I'll show you some of our aggregate data that we have so far, really where we are. But then we're really going to turn it over to Dr. Jenkins, and I hope that you will feel free to be chatting in questions. I know that you're on mute, but that doesn't mean that this has to be just a one-way conversation today. We really do want you to be able to ask questions throughout, get your questions answered. So please use that chat box that you see on the right-hand side of your screen. As questions come up, please chat them in. Or if you want to be sharing what you're doing in your organization, you'll have an opportunity at the end for that too. But as it comes up, please feel free to share. And we'll be calling that out and making sure that we're talking about it. To introduce Dr. Jenkins, he is a clinical professor of medicine at UCSD, one of the authors of many, many publications on this topic, led many large studies on the subject, among others too, but he's going to walk us through a methodology that brings high reliability to VTE prevention here. And I think you'll really like it because it is quite innovative from what I have seen across the country here. Also, just a little bit of housekeeping here. In addition to remembering to chat any questions into the chat box, we will have a recording of this webinar will be available in about 3 to 5 business days. The slides, if you want the slides, anytime, they are available to download in the bottom left-hand corner of your screen right now in the files box that you see there. You can download those now. And then CEs will be provided via an email link following this webinar. But in order to get them, one caveat with our CE provider is that you must chat in your name and the organization that you're with into that chat box. So please type that in. It also helps us to know who's in the room and where you're coming from. So please do that. So with that, let me just quickly take us through just a brief look at what we're talking about when we're talking about the data for VTE. This might be a little bit difficult to see, but I think what you can see here is that red line there represents all of the hospitals. This is not hospital-specific data by any means here at all. Our blue line is our baseline that goes across that you see there. The red is our performance so far since baseline, and the green line represents our goal rate. So as you can see, we are definitely moving towards the goal rate, maybe. What you probably can't see, since it's pretty small there at the bottom, is the number of hospitals that are actually submitting this data. And unfortunately, for the last couple of months, we're only at about a 25% rate of all hospitals that submitted baseline data that are currently submitting ongoing monitoring data here. So while it looks like we've made this massive improvement, not quite to the goal yet, but made this massive improvement, I don't know if that's a true look at this. Hopefully we've made even better improvement, and if all of our hospitals were submitting the data, then we could really show this. And this is the kind of work that we have to show our data in order to be able to continue getting funding for these types of opportunities and to be able to provide all kinds of education. So the more that you can be submitting this data, the better, because we really do want to show CMS all of the hard work that our hospitals are doing. It's not us doing the work, it's all of you, and we know that, and we are so appreciative of everything that you are doing to improve outcomes for patients. So let's just get credit for it too by making sure that we're submitting that. So that's the only bit that you need to hear from me, truly. With that, I'm going to turn it over to Dr. Ian Jenkins again here. So Dr. Jenkins, take it away.
Okay, thank you very much for your kind introduction. I'm just going to dive in. The only thing to see on this first slide is there's an email address. So if anyone has any questions after the webinar ends that don't get answered, feel free to hit me up by email. And I do have no disclosures, but I will say that I've worked in the bucket model and with the SHM model. And for that reason, I'm a fan of those. So I guess that's a disclosure, but not a financial one. So our objectives for this talk are to understand the barriers and failure modes with VTE prophylaxis, to review the techniques for optimal VTE order set design and implementation, and then also to get the skills we would to implement measurevention, which is real-time monitoring and the correction of deficits. An overview of the talk, we're going to briefly cover how things are going right now. We have problems with under and over treatment. And I'll also talk about some of the ongoing controversies in the literature. This is actually a very complex area, but I'll try to touch on it. And then we'll look at the quality improvement principles needed for VTE prevention projects. And that includes just an overview of the quality journey in general, techniques for intervention, how to do a proper implementation, how to design a good VTE prevention protocol, and tips for running the VTE program. And then lastly, we're going to focus in on one technique which is really useful if you want to get to near perfect prophylaxis, and that is measurevention. And I'll refer you to some additional resources at the end. So first thing to say is that we do have a problem with significant under prophylaxis. And I'll give you a couple examples here. The large ENDORSE study looked at 70,000 cases in almost 360 hospitals and found that only about half of patients were on appropriate prophylaxis, with a slightly higher rate among surgical patients than medical patients. And a review done in the Journal of Hospital Medicine looked at a huge number of cases, almost 400,000, 429 hospitals, and they found that many patients got some dose of prophylaxis, so almost 80% of surgical and about 2/3 of medical patients. But what they found was that only 16% of the surgical and 13% of the medical patients actually got appropriate prophylaxis. So the right drug every time it was needed throughout their hospital stay, discharged on the right thing if that's applicable. So we have a long way to go. These are just two examples. Now the flip side is there have been many discussions about how we need to do a better job, and I think that's appropriate. But I've also seen problems with over-prophylaxis, and this is one of the big issues on the literature, is whether we are doing too much and too little at the same time. So this is just a case report. Basically, this woman was, she burned her hand in a campfire, and she was going to be admitted to the burn service. And at my hospital, the burn and trauma services believe that all of their patients are very high risk, and so they put them all on enoxaparin 30 milligrams twice a day. However, after this person was admitted, the residents came down and said, hey, she actually could just get some bandages on those hands and leave. She didn't need to be in the hospital at all. She didn't need any DVT prophylaxis. And I only found out about this because she was admitted for mild alcohol withdrawal, and then they decided the burns aren't a problem, but send her to Dr. Jenkins for alcohol withdrawal. Of course, giving patients too much prophylaxis is expensive. It hurts. It wakes people up. It can cause delirium. And there are small risks of getting heparin-induced thrombocytopenia or HIT. A patient could experience bleeding, bruising, or hematomas. And you're also talking about a big investment in nursing time. So we don't want to give these drugs when they're not necessary. Another thing to point out regarding overprophylaxis is an important study relatively recently from Michigan. They looked at 20,000 medicine admissions from 35 hospitals, and they found that the majority of patients received some form of VTE prophylaxis. The VTE rate overall in this study was about 1.1%, which is, not negligible. That's an important problem, but it's not terribly common. The thing that was concerning is that the rate of VTE in patients who went to high-performing hospitals, which gave about 86% of their patients prophylaxis, was the same as the VTE rate in patients who went to low-performing hospitals, who gave just a little over half of their patients VTE prophylaxis. They found that many of the patients that had venous thromboembolism had received some prophylactic intervention, meaning that they were failures. And some authors have gone on to interpret this study as meaning that at least medicine patients don't really benefit from DVT prophylaxis, or that we shouldn't bother having efforts to reach high performance because they have the same VTE rate at these high and low performing hospitals. Now there are some caveats. They really just looked at the first 2 days of hospitalization, and for them, if you got 80% of your days or 2/3 of your doses, that was considered adequate. We wouldn't consider that optimal. I think it's a leap to suggest that the patients didn't benefit, but what this does tell me is that if you reach your higher risk patients, that's where almost all the bang for the buck is going to be. We don't have to get every patient on DVT prophylaxis. Many of them are low risk, and they don't need to receive something. So we have to be attentive to both over and under treatment. So there's even more controversies out there related to challenging guidelines. The first of these is the ACP guideline, American College of Physicians, and they published their first guideline in 2012. And sad to say, this guideline doesn't provide much guidance. It does say that you should use a mechanical device for patients who can't receive a drug. That would be intermittent pneumatic compression, or IPC, rather than a compression stocking. But that's the only really concrete thing they said. They gave the general suggestion that you should use drugs when the benefit is greater than the risk, which is not terribly helpful because I think anyone would have said that. They provided no guidance on how to risk assess or how to decide which patients to treat or how to implement a protocol. So this is a guideline without guidance. And people who are working in this field will then turn to the ACCP guideline, or the American College of Chest Physicians, where there was much more concrete guidelines. Unfortunately, their suggestions are very complicated and cumbersome and specific. So they said, first off, for medical patients, you should use something called the PADO score to risk assess. For surgical patients, you should use the Caprini score. For orthopedics, there was a menu of acceptable options. And the problem with this is now you have 3 different systems you have to implement in your hospital, which is intrinsically complicated. And to make matters worse, the 2 first systems, PADO and Caprini, are point-based, which means that you have to rely on doctors to add up a bunch of points and come up with a total score and then determine whether that merits prophylaxis or not. Unfortunately, most doctors don't seem to do this reliably. And I could go into the details of why that happens and how computers can sometimes help a little bit, but that's probably not enough now. So instead of those 2 models, what we actually recommend through the Society of Hospital Medicine is that we use something called a bucket model for ease of implementation. It's been successful for us at UC San Diego, and it's been implemented at numerous hospitals which have seen reductions in VTE rates, and that's why it's our preferred protocol. I don't have a randomized controlled trial for you, but I do have a number of real-world improvement efforts that have worked, and that's what we feel is perhaps most relevant to the implementation field. So I want to briefly touch on the point scoring systems recommended by the CHEST guidelines. This is the PADO scoring system. It's for medical patients. And you can see that if you have something that's more dangerous, like a prior clot or active cancer, you get 3 points for that right away. But you can add up the rest of that stuff, and then you're supposed to prophylax patients that have 4 points or more. One of the problems I have with this is I don't feel it's a truly representative look at my patient's risk. 40% of the clots at UCSD are related to central venous catheters, and yet that doesn't appear anywhere on the PADO scoring system. So for me, I feel like that's a major hole in this. The other thing is if you look at their results, the high-risk patients who didn't get prophylaxis had a 12% rate of thrombosis, which is very high. And the patients that were just 1 point below that or even more safe, they had a 0.3% risk of venous thromboembolism. And for me, we need to do a serious reality check because every piece of research that I know of suggests that as you get more and more VTE risk factors, your VTE risk increases incrementally. It's not an either-or phenomenon. So I'm not really sure that this paper could be duplicated and show that this point scoring system could just divide people into patients who are and are not at risk for VTE. That just doesn't fit with anything else that I've seen in VTE research. This is another thing to look at with Padua. That donut on the left is the different types of patients they had in there. And one thing to point out is that green to the right of the donut, those are the patients at their hospital that needed anticoagulation. So this is a very interesting hospital. 44% of their patients had to be on full-strength blood thinners. That is not like any hospital in the United States that I've ever worked at. And then if you look at the low-risk group, that's the red bar. They are a little bit less than half of the population. And this low-risk group was a very strange population of hospitalized patients. In the whole study, only 2.5% of the patients had a contraindication. I admit more patients with GI bleeding alone, never mind thrombocytopenia, coagulopathy, history of heparin-induced thrombocytopenia, you name it. That is a very low contraindication rate for my patient population. They only had 1% or less of their patients were immobile, which to me is striking because I have a great many patients who are too sick to get out of bed or don't do it more than like just to the bathroom once a day or something like that. So that's a very low immobility rate. They only had 6% cancer, 6% obesity. America is much more obese than Italy, it would seem, from this information. And then 12% of them had infection or inflammation. And so most of my patients have an infection, it seems. And for all the lack of acuity in their patient population, they still had an 8-day length of stay. And so I find that this group of patients is very unlike any population I've worked with in the United States. And for me, that calls into the entirety of the study into question. It just doesn't seem relevant to American hospitals, at least the ones that I've worked at. And I would also point out that the patients who had a score of 3, they still had a 1% risk of pulmonary embolism. A lot of people would feel that that justifies prophylaxis. So this, for me, Padua is not the best system and more research needed. For general surgery, it's probably even worse. This is the Caprini model, and you're supposed to go through all these things and add up these points. And I will just say in brief, physicians don't do this. And there's a couple of reasons why. The first thing is, if you look at those curved arrows over on the left, I honestly don't know if you are septic from serious lung disease, including pneumonia, which caused abnormal pulmonary function, whether you should get 3 points or 1 or what, because those seem duplicative. And it's also a little bit duplicative if you have a medical patient at bed rest from sepsis who is confined to bed, or someone that had something else that immobilized them. There's, like 5 easy-to-find things on this list that all relate to immobility. So for me, it's very confusing. And I just don't think doctors are going to add up these points reliably because if you look, patients that have an acute major stroke, patients that had major orthosurgery or acute spinal cord injury, they need prophylaxis. I don't need to add up points to reach that conclusion. I know that already. So as a physician, I'm not going to use this system for people that I know need prophylaxis. I'm just going to give it to them. And then there's heparin-induced thrombocytopenia on this list. Those patients don't need prophylaxis. They need full-strength anticoagulation with a non-heparin agent. So again, this is a research tool. It wasn't designed to select patients for prophylaxis. This is designed to measure their VTE risk. And again, there's some issues with implementation of this. Interestingly, in that study that's mentioned in the references down there from 2009, when they applied this to a general surgical population, they found out that 90% of the patients needed some form of prophylaxis anyway. So it's not as if doing this helps you avoid prophylaxing your surgical patients. So what's left? What should we do? If the Padua and Caprini score systems are complicated, should we just let the physicians do whatever they want? I would say no. We have watched hospitals without any form of system. Their VTE prophylaxis rates are usually less than 50% reliable, but we feel that there's a simple way to do this, and I'm going to get into more of that later, but we do feel like there is a reason that we have to have a protocol to take care of these inpatients. But now I want to talk about some principles of quality improvement. This is an overview in like one slide of how to do quality improvement. So obviously it is a abbreviated summary, but it is there to remind us that we can't just plop a protocol down in the middle of a hospital and expect it to work. There is a process we have to go through if we want success. The first of which is to form a good team. So you need physicians, usually a physician leader or a quality leader, then experts. Pharmacy is always involved, information technology or forms if you're a paper hospital, an executive sponsor so that you know you're in communication with the C-suite and they're going to give you the resources you need. And you really have to reach out to the stakeholders. If you don't contact the people affected by your protocol when you're designing it, you're going to make enemies, and when you roll it out, they're not going to want to participate, and they're actively going to resist it. So it is crucial that you make friends with the orthopedists, the neurosurgeons, the OB-GYNs, the general medicine people, pulmonary, and find out what their opinions are so that they become part of the team and not a potential enemy. Next step is to assess your baseline performance. You have to figure out what areas you really want to focus on, and you have to define kind of what you're going to study. If you don't have data, you can't improve anything, so you really have to decide what measures you're going to follow. Once you know how you're doing and you have an idea where you want to go, it's time to obtain institutional support, and this means usually presenting at some committees. You need to have a business model. What's going to be the return on investment? How much is this going to cost? You want to appeal to patient safety, of course, compliance with applicable regulatory or monitoring bodies. So if there's publicly reported outcomes, your hospital is usually more interested in that. And it's nice to have a human rationale. In other words, some kind of gripping story. If you know of a patient that got a clot at your hospital that was avoidable, tell that story at the committee so people remember we're not talking about numbers. We're talking about individual patients getting hurt. And one other tip for those meetings, I always like to recommend that don't go in there cold. Talk to the people that will be there ahead of time so that you know what their concerns are. You can address them so that they go in comfortable with what you're going to say rather than skeptical. And then you can build their expertise and their concerns into your presentation as well. That really helps the presentation to go smoothly. At this point, you can identify the best practices. What is it that we feel people should be doing with our patients? And then you write an aim statement, something that is time-bound, something that's very specific, something that's measurable, something that's meaningful to patients, that will hold you accountable and really help define your mission. Then you have to choose your metrics. Again, are we going to study just VTE prophylaxis rates? Are we going to study adequacy? Are we going to look at too much as well as too little? And you really have to think about data collection. Data collection is frequently very time-consuming, and it can be expensive. And so you have to think about what's the most effective way you can get information on VTE prophylaxis. Is it going to be spot chart reviews? Can you pull anything automatically? Are you already using some resources to get data for joint commission measures, in which case you can use existing measures if you're satisfied with them, things like that. Only after all these steps are taken do you want to plan and deploy your interventions to fix your system. And then, of course, you are sure to need several PDSA cycles, Plan, Do, Study, Act, to help learn and refine your processes. That's the spirit of Kaizen or continuous improvement. So it will be a long-term struggle. You just have to hunker down and be ready for that. Very important to understand how things work at your hospital. So I recommend doing what we call an environment scan. This is where you go out into the real world where care is provided and you look at the order sets and protocols and the behavioral patterns of DVT, PE prophylaxis at your hospital. So for example, at my hospital, again, all trauma patients are considered by our trauma service to be high risk, even if they're not actually sick, they never had a major injury. And so I think that's an area where they may over-prophylax because they just have this as a gestalt. All my patients are high risk. And that's not true. They're not individually assessing them. You want to know how much pharmacy oversight there is for the physician orders, things like that. It helps to take what we call a Gemba walk. This is a term from like Toyota production model, where you go out there and talk to the frontline workers, and you watch them do what they do, admit a patient from the ER, and you see how crazy their jobs are and all the different things that are going on, which will really help make it clear that you need to provide a tool that is easy to use and very fast for these workers, or you will find that they have to click around it because there's just so many competing priorities for them. It's nice to have some data on outcomes. What is your VTE rate? If your VTE rate is already excellent, you might want to think about doing a different project. If you have certain problems, perhaps a high VTE rate on a certain service, that could help you focus all your efforts in one place and allow you to be much more successful than if you blindly just tried to fix the entire hospital when most of the hospital was working well. So that helps really define the problem you're facing. And it helps also to map the process of getting patients on VTE prophylaxis from the moment they're admitted until the drugs are delivered and the patients are discharged. It helps to use the whole team for this because everyone has some specific knowledge that everybody else lacks. And you really want to get down there to the nitty-gritty and identify the high leverage points and vulnerabilities. How do we make mistakes, for example? One example at UCSD, sometimes we order a medication for a patient, the patient refuses it, and that's the end of it. And that is actually a failure on our part because in a high-performance system, we would do a better job of convincing the patient they need the medication, or if they continue to refuse it, getting them on a mechanical device and notifying the physician rather than just letting the issue rest. So that's an overview of understanding your process. And now it's time to talk about how to fix it. So these are some interventions that you can do that don't work that well. Education is crucial, but education alone is not going to do it. Most of our problems in hospitals are not knowledge deficits. Instead, they are really smart people trying to do their best in a tough situation. You can tell people to work harder and pay more attention, but until you've walked in their shoes, you might not realize how hard that is or that they're already doing their best. A lot of hospitals are satisfied when they produce a policy and a procedure, but if the frontline workers never heard about them and they're just sitting on a shelf somewhere, that doesn't help any patients. Audit and feedback is another method. This does actually work somewhat. So if I get a report saying, Dr. Jenkins, you failed to do this 20% of the time or something like that, I may pay more attention going forward, but it's always late. If I get that report that I missed on 20% of my patients, I've already failed those patients. They came in and they had VTE risk and it wasn't dealt with. So that's a problem. And a lot of physicians, there's just too many things going on. When you separate what they're doing with VTE prophylaxis from the message about the VTE prophylaxis by several months, it's hard for them to really connect them and change their practice. Penalties and rewards, sort of same things happen. And a lot of hospitals don't have rewards that they can dole out to all the physicians. But the number one thing to avoid would be something that clinicians hate. Key rule here, never disrupt the clinical workflow or reduce the doctor's productivity. If they find themselves clicking through 5 minutes of screens to do DVT prophylaxis, they're simply not going to use your protocol, and they will ignore it. So key measure. All right, how about some methods we can use that are more effective? These are some interventions and principles for venous thromboembolism. One general rule about quality improvement is you want to have what we call standard work. So you want, ideally, for them to be one order set in your entire hospital, or if there is an exception, that it's very limited and service-specific. So that might be like orthopedics. They're the most common group that gets excised from a single hospital order set. And this is so if you have residents rotating through different situations, they don't have 5 different systems to learn. If you have nurses going to different floors, the practice is the same everywhere. So standard work is very important. A next key principle is going to be guidance at the point of care. You want to have your protocols and advice and the warnings available to the physician at the moment they are ordering the drugs or devices. It's nice to embed some of this information in the protocol, and it would be really great if the computer could actually advise the physician. So instead of just having a menu of choices, and let's say enoxaparin 40 milligrams is one of them, the computer could know the patient has chronic kidney disease and suggest a lower dose or the use of unfractionated heparin, which would be safer for that individual person. Redundancy is another key principle. So this relates to the issue of the Swiss cheese model, where an error that reaches a patient is always the result of multiple failures. So if you make more slices of cheese to protect your patient, none of them will be perfect, but they can build a safer sandwich, I guess, is what we'd actually be doing there. So what would be the redundancy in VTE ordering? Well, one thing is when I order the medication, I think about the patient's renal failure. And then the computer could check and say your patient is insufficient renal function for the drug you ordered. And of course, a pharmacist could oversee it before that order is validated. When you have those 3 slices of cheese there, it makes it much less likely that the wrong drug will get to the patient. A standard quality improvement rule is to try to default the best choice. I will say that you don't want to do this for venous thromboembolism, because if you just have everyone ordered for a drug, many of the patients won't need it, or it'll be wrong for that patient. And you'll have patients coming in for bleeding for whom the doctors just leave the drug checked. That's not a good idea. So I wouldn't say you should default the best choice. You might want to put your preferred drugs higher on the list or limit the number of choices, but you don't want to pre-specify anything. You do want to make the doctor think about it, though. So I recommend that we always ask the doctors to do a risk stratification, and that it also be required to pick some intervention, either a drug, a device, or a certification that the patient is low risk and doesn't need either of those things. So this menu sort of provides a list of the more successful or stronger quality improvement strategies to pick from. So I now want to get to the bucket model, which is what we do to risk stratify our patients. Again, this is off guidelines. I just want to emphasize that. The idea is actually derived from the, I think, 7th or 8th edition of the American College of Chest Physicians guidelines, but they have since moved away from this strategy towards a point scoring system, Caprini or Padua. We have not followed them in that change. We think that this model was very successful for us, and we intend to continue using it. So how does it work? Remember when I said that if I admit a patient that had major ortho surgery, I am not doing any math to figure out if they need any kind of drug, because I know by gestalt that patient falls into the high-risk category. I can tell instantly, with a little bit of education, that a major ortho surgery, multiple major trauma, acute spinal cord injury with paresis patient, intraperitoneal or spine cancer surgery patient, someone who had craniotomy, or a critically ill patient is obviously a high-risk person. And I don't need to do any additional math to figure that out. That is gestalt. That person is in the high-risk bucket. Who's in the medium-risk category? This is a little bit more complicated, so I'm going to skip over it and go to the low-risk category. These are people that don't have much going on. They either have OB status, or you think they're going to be in the hospital less than 48 hours. Someone who got better. Let's say someone had pneumonia, and they're awaiting placement, and now they're no longer febrile, and they're walking up and down the hall off oxygen. That patient's prophylaxis can be stopped. Or if they were never that sick, sometimes patients end up in our hospitals because they need a workup, or they have a chronic disease, and they have to be in the hospital for treatment. But they're no different in their health than they were at home, and they're not on prophylaxis at home. They don't need to be on it in the hospital. And the other group that I think surprises a lot of people, everyone knows cancer is a high-risk situation for VTE, but if someone is just admitted to the hospital for chemotherapy and they're ambulatory, we do not prophylax those patients either. The last category, the low-risk patient, is someone who is not a medium-risk patient. So if you have someone that doesn't meet those criteria, they would also fall into the low-risk category. So let's jump back up to medium and think about who that is. If you have moderate or major surgery plus something else, you're a medium-risk patient. So that could be impaired mobility. It could be another risk factor, like a history of a prothrombotic condition. If you're a cancer patient and you have something else, you're a medium-risk patient. So that could be an acute illness. It could be another risk factor. It could be history of venous thromboembolism. That would be enough, obviously. If you're not a surgery or cancer patient, if you're an acutely ill medical patient and you have an acute medical illness, again, something else on top. That means that if you have reduced mobility, a history of clot, or thrombophilia, you would categorize that person as a medium-risk patient as well. This is the area where I think things are a little bit different. We have made the medium-risk patient the definition be of someone who's a little bit sicker ever since the 2012 chest guidelines came out, which emphasized that we probably were over-treating some of our patients. I do agree with that. I think we used to sort of say that most patients need to be on prophylaxis, and then we just gave it to a bunch of people. Now we're a little bit more careful about who we apply that to. We don't want anyone to get treatment that they don't need. So these are the high, medium, and low risk groups. With a little bit of education, most of your clinicians can tell which type of patient they're dealing with by gestalt. And they don't have to do any math. They don't have to look anything up. They just sort of know, does this patient need prophylaxis or not, based on these buckets. And now I want to move on to how we might implement this as an order set. So this isn't a screenshot of a whole protocol. You can see that the risk levels are up there on the top. You could either provide that to the physicians, or you could make it a link. If you've educated them well, you can always just say, like, click here if you want to know a reminder. That way it'll take up less space in the order set. If you don't have that functionality, or you want to make sure they look at it, put it up there. But remember, most people are not going to read this every time they admit a patient. They're just going to go based off their memory and their gestalt. Then you would have 4 choices to pick from. And this is a required functionality. So when you admit or transfer a patient at UCSD, you literally cannot do it without certifying that they are high, moderate, or low risk, or that the patient is already anticoagulated and therefore low risk. So once you pick one of those options, which you are forced to do, you're confronted with suggested interventions. I want to show you what happens when you check moderate risk. It opens up this drop-down menu, and you have to pick one of 4 options. The first one is enoxaparin. I'm not recommending enoxaparin. If you're at adults-parent hospital, that's great. This is just the one we use. And notice that I've put a warning there, don't use if the GFR is low. So that you're instructing the physician here. If you chose that the patient is moderate risk, these are the acceptable choices for that level of risk. And we've also started to provide guidance at the point of care about who this is appropriate for. At UCSD, we do something where we recommend 3 times a day heparin for most patients, but only twice a day if you're elderly or you are a small patient. Not every hospital does that. It's optional. But because we provide both of those choices, we're giving doctors guidance about which one to choose when. And if you have a contraindication to anticoagulants, for example, your patient is bleeding or has platelets of 20, then they just check the box that says contraindication to anticoagulant, and that automatically orders the device. So we use intermittent pneumatic compression. We don't have any compression stockings. The evidence is worse. So the next thing to look at is if you picked low risk or anticoagulated, it's pretty easy. You just include a device there for early ambulation, no drugs, no devices for that subset of patients. So the tricky group to think about how you're going to prophylax is the high-risk group. So why is this so tricky? Well, the first thing is there isn't just one kind of high-risk patient. Enoxaparin might be appropriate for cancer surgery, critical illness, or a newly paralyzed patient that had a major stroke or spinal cord injury. However, there's a whole bunch of choices for the orthopedics population. Enoxaparin, fondaparinux, vitamin K antagonists, all the new direct oral anticoagulants, the DOACs, or NOACs, some people call them, the new oral anticoagulants. And some groups would also permit the use of aspirin in this population. But it's very complicated. You don't want to use aspirin for total knee replacement. If you do use it, it should only be for total hip replacement. You don't want to use the direct oral anticoagulants for any medical patients. They don't work and haven't been studied well enough in that group. So if you have a high-risk medicine patient, you don't want them just choosing from a menu that says that rivaroxaban, apixaban, dabigatran, et cetera, are okay, because they're not okay for medical patients. So this makes your order set design much more complicated. And you'll still have to have heparin because your patient might have renal failure. So how do you handle the complexity of the high-risk patients? Well, one is to carve out an orthopedics menu. So everyone gets admitted to the hospital, sees the same screens except the ortho patients. That's helpful. Another thing to do, if you can, and many hospitals cannot do this, is to get all the orthopedists to agree on a strategy. If all the orthopedists agree to use enoxaparin, it's fantastic. Then that'll be your strategy. If they want to have an oral anticoagulant at discharge, then you could pick one of the new ones. That will make things simpler, and you could append some guidance with that option. So if there's a rivaroxaban option, for example, it could say only used for orthopedics patients, something like that. Your other options for dealing with the complexity of high-risk patients could be more education, which is a little bit tricky, or a pharmacy backup check where someone would go over the protocol a little bit more thoughtfully. And I got to be honest, pharmacists seem to be a little bit more thoughtful when they review these orders than the physicians are when they place them. And I think that's just how we're trained, and the doctors feel like they've got other things to do. In the example of orthopedics, everyone came in for something like a hip fracture or a knee replacement. They never came into the hospital for VTE prophylaxis. So I think doctors don't give this quite the attention it may deserve. But pharmacists are usually a little bit more reliable in reviewing these types of things. Whatever you do, make sure you've involved all the stakeholders with your order set design. You don't want to anger anyone who comes into work one day, finds out that these new rules are forcing them to do something that they don't feel is appropriate, or that they weren't consulted, because physicians find that rather annoying. In fact, we all do. This is a list of contraindications we use at UCSD. We don't aggressively police this. These are just some suggestions we have. So, thrombocytopenia, high INR, low hemoglobin, if you feel like the patient needs a little bit of a buffer if they were to bleed, recent active bleeding or bleeding disorder. Critical site concerns. This is a major one. We have a lot of trauma patients that have major injuries, including CNS injuries. We leave it up to the doctors to decide when they can go on. And for surgery, when we're doing research on our population, we recommend initiation within 24 hours for most patients. For transplants and major traumas, we recommend 48 hours. For the brain and spinal cord, we recommend physician discretion. And we allow doctors to document all sorts of other contraindications, like retinal surgery or something like that is up there. In general, most order sets can do without displaying these on the CPOE screens. You can probably provide them in the link or educate doctors to them. We don't want to have a very lengthy protocol part of every admit and transfer. it would just take up too much space. But you do want to have this information out there for the physicians somewhere. So it gets even harder. What about obese patients? We have a lot of patients that are obese, and it's hard to know what to do with them because you can't account for the different levels of obesity in one protocol. So some patients are obese and they're relatively standard size. Other patients are obese. I just had a patient about a week ago whose BMI was the highest I'd ever seen, was 84. So there's just no way that you could account for that patient on these screens. What I would recommend is that you leave this issue to pharmacy. When pharmacy validates these orders, they should be thinking about the patient's mass and making recommendations. If we have questions about this, I can go into exactly what drugs or doses to recommend. There's always a renal function issue. If you place warnings on your order set, that's helpful. The pharmacy check is really important. And one thing to keep in mind, depending on the ability of your pharmacist to keep on top of this, patients' renal function changes. So if someone was on unfractionated heparin initially, but it's not the best choice for them, you might want to switch them. If someone develops worsening renal failure, then their low molecular heparin might not be appropriate any longer. And so it's helpful to have a mechanism to follow this over the hospitalization. Liver disease, another difficult issue. My hospital does liver transplant. We have a lot of liver-injured patients. We do know that they're not reliably protected by their elevated INR. That's just a lab test. It doesn't actively reflect what's going on inside a liver patient. And because this is very poorly studied and the risks are likely higher, we let the physicians decide what to do with the end-stage patients. And it's helpful to get hepatologists involved in order set design so you don't do anything that makes them anxious. Let's talk about some pitfalls with protocol design. One thing is the thoughtless obedience. This is a picture of a car where the driver decided to follow their GPS to the letter, and they just took the instructions to heart and they tried to drive out into that lake. It's not doctored. This is a real picture. If you Google it, you can find that there's a whole bunch of these examples where people have gone off bridges or done other crazy stuff because of the directions from their GPS. So one example of this would be if you have a patient who came in bleeding or had some other contraindication. The doctor sometimes leaves or orders heparin because they just thoughtlessly are clicking in rapid succession. This is obviously a potential problem. There isn't a perfect solution for this. At some level, physicians need to be responsible for the orders they write, but it can be a tricky situation. But the main point here is that whatever you put out on the protocol, the physicians are going to trust. They're going to say, this is what the hospital wants me to do, and they're going to follow your advice, so make sure it's good advice. The next thing to say about this is that perfect is the enemy of good. You cannot write a perfect protocol. If you try to have it so complex that it addresses every situation, then the physicians are going to ignore it because it's too long. So you have to really balance those issues. This is where piloting your protocol with the end users is really helpful. And the reason I put that blue bird up there, that's the icon for Twitter. Remember, this is a Twitter generation. If you have young physicians or even the older physicians, we all think in like 120 characters now. So it needs to be brief and functional, not complicated. And then, of course, the issue of human error. Pharmacy may catch many of the mistakes the doctors make, but if we really want to do a great job, we need to have some sort of recovery system for high performance, and we'll talk about how to get there. This is an implementation tip screen. That's an ounce glass up at the top. It's there to remind me that an ounce of prevention is worth a pound of cure. You do not want to have a launch like healthcare.gov. I'm going to be really careful about this. So have a consensus between all your stakeholders and your institution. Make sure that everyone's on board with the protocol before it launches. Remember, doctors resist change a little bit, but more than resisting change, we resist being changed. Nobody likes to be told what to do. It's like taxation without representation. We don't like it. We also think that if something seems not to fit our patient population, we will ignore it. So if we haven't been consulted about our special type of patient, we may ignore your protocol. So again, stakeholder, stakeholder, stakeholder. Education. When you admit patients, you may find that they're not actively reading your protocol each time. Doctors are not going to do that. They're going to sort of click through it. So you want to make sure that the physicians know what's in there and generally what they should be doing, because they have to understand it and they have to believe that it's important when they get to your protocol. Doesn't matter what you write. If the physicians aren't prepared to use it intelligently, it's not going to achieve high performance. And of course, before you implement wide, you want to try at least a bunch of volunteers or potentially a pilot unit. So now let's talk about measurevention and try to wrap things up. Measurevention is a combination of measurement, active monitoring, and intervention, or real-time correction of defects. So why do we need this? Well, the order set is going to catch most of your patients, but not all of them. What if a patient came in bleeding or thrombocytopenic, but those things got better? Later on, they might need prophylaxis. What if somebody comes in and they need a procedure so the heparin is stopped, but then the doctor fails to restart it? This is actually pretty common. And then what about somebody who was on heparin and then they got better and the doctor never stops it? So the patient spends a month in the hospital waiting for placement, but they're no longer acutely ill. That's a mistake too. So how does measurement work? In brief, the first step, somebody needs to look at all the patients in a unit, on a hospital, on a service, whatever, for appropriateness of prophylaxis. And then when they notice a problem, they call the doctor to get orders to fix it. And this happens in real time. Here's three key tips for launching the measurement thing. First one, you have to wait until your performance is already good. If you have a 500-bed hospital and your performance is 50%, the first day you start measurement, you'll have to call about 250 people, and the doctors and the nurses are immediately going to hate it, and they're going to push back, and the project will fail. If you wait until you're at 90%, on the other hand, you'll only have to call about a small fraction of that, and then it'll be less work, and it will be better received. Tip 2, you can learn a ton of lessons piloting in a receptive unit or on a receptive service before you go hospital-wide. You might want to just roll this out in blocks, not as a whole institution at once. And tip 3, you really have to think about good behavior on the part of the physicians. If a nurse or quality person calls a physician and says, hey, I think this person should be on prophylaxis, and the doctor yells at that person, it poisons everything. So whoever's doing your measurement should know that that behavior will not be accepted, and they should have someone they can contact if there's bad behavior, someone that will back them up. And this is where institutional will comes in. If it's the chief of surgery yelling at your measurementist, someone has to be willing to talk to the chief of surgery and say, that's not how we treat these people, and make sure that it gets better. That's a big step. Here's data from a trial that was done by Jason Stein in Emory. He had 3 units, and he staggered a measurement intervention. You can see that in the blue, they had variable performance, and after he started measuring, it became excellent, usually 100%, and much more reliable. The green unit had significant improvement, still some variability, and the orange unit at the bottom, again, when you started doing measurement, they shot up to 95 to 100% right away. So very powerful intervention. The problem is it's a lot of work too. So how do you spread out the work? I think the key principle here is many hands make light work. If you can afford a quality specialist to do this, that's great. But remember that person has weekends, holidays, nights, that sort of stuff, and they can get tired of this. That quality person probably has other jobs too, or might be, there might be a better way to spend that money. So what are some alternatives to a dedicated quality specialist for measurement? Well, one is to embed it into rounds. This works really well in the ICU because they usually have all the doctors and nurses talking about one patient at one time. They can go through a safety checklist and make sure that DVT prophylaxis is discussed. You could have a pharmacist embedded in the teams looking at this on rounds or responsible for a certain unit. It could be a nurse manager. It could be done on unit rounds. I will say if you're going to try to use all the doctors or all the nurses, that probably won't work. It might, but remember that the doctors tend to copy their notes, and they could be writing every day continuum enoxaparin and continuum heparin, and in fact it's not ordered because they're just copying their notes over, and the doctor might be unaware of that. The individual nurses, there's nothing wrong with nurses, but if you have to train all the nurses in your entire hospital to do this, it's just way too many people for it to be reliable. And so it's helpful to have more of a core team of measurementionists rather than everybody trying to do it. One thing that really helps too is information technology support. This is a screen we have at UCSD. You can pull up a unit. This is the 2 West unit at my Thornton Hospital. And you can see just by looking, everyone that's green has a drug ordered. And I know they're all right. The next group are the orange groups. These are people that have no drug ordered, but the computer can tell they have a lab contraindication like thrombocytopenia. That's fantastic. I don't have to focus on these patients. I can go right to the yellow patient who has no drug ordered and doesn't seem to have a lab contraindication. So that person is missing something probably. At least they have SCDs ordered. That's in the 4th column from the right. Or the red patients. These people have nothing ordered, and that could be a sign that they're not properly protected against clots. So just having something this visual, or even a simple list of patients with anticoagulants next to it, really helps the measurventionist focus on their work and identify the people that need phone calls super fast. That saves a ton of time and makes this much more sustainable. Speaking of sustainability, one thing to be afraid of with VTE prophylaxis or any project is that all the poor nurses and doctors out on the wards feel like they're being yelled at. And there's like 20 projects, and they have to comply with this, and they have to comply with that, and it's always changing. This is not good for quality culture. This makes us all feel like we're just being tortured, and none of it really matters. So you don't want to have a project of the month flavor. If you can, I really recommend trying to organize with administration so that all of your projects are dealt with in the same way. So for one example would be having safety rounds on your patients, where you could discuss things like UCSD has a big problem with elopement risk. We would talk about that. Wounds and skin protection, VTE prophylaxis, removal of central lines, removal of Foley catheters. All these things can be done at once, and then the units can perceive that this is a single safety project with multiple facets rather than a bunch of disconnected projects. And that can be, yield a lot of dividends because it's more organized and more acceptable to the frontline workers. Just in brief, I will show you two things you can get more information from. This is the AHRQ VTE Improvement Guide. It's free. All you have to do is Google that subject heading up there, AHRQ VTE Improvement Guide. It'll pop right up. You can download it for free. And a similar set of resources can be found at the SHM VTE Resource Room. Again, just Google that phrase, and you'll find an entire quality project laid out for you step by step with an improvement guide that you can download. So just to review, I want to do this quickly because we are running out of time. Some barriers and failure modes are clinician knowledge gaps, disagreement with a protocol, an ineffective order set that's cumbersome to use or annoying, or doesn't provide guidance at the point of care, or that can be skipped. Patients that have clinical status changes, like their bleeding risk got better or the patient got sicker, and a bunch of special circumstances, like obesity, renal failure, hepatitis, thrombocytopenia, and allergies. There's a bunch of others. These include patient refusals and failure to apply. That means not bringing the drug to the patient, or more often not applying the squeezers, IPCs. That happens quite often at my hospital. Tips for your protocol design: use a proven quality improvement framework. Make sure you get stakeholder and institutional agreement before you get started. Don't forget to balance guidance with complexity. You want to have an easy-to-use protocol when you launch. You want to have a simple risk assessment that's paired to a menu of options. That might be the single most important thing for a VTE protocol. Don't have a complicated point scoring system, and make sure you don't just provide a menu, that each thing is recommended based on the patient's level of risk. Guidance at the point of care is very helpful as opposed to somewhere else where the physicians won't look it up. And mandating use of the order set with a hard stop strategy is crucial too. You will have special exceptions and errors, so make sure that you have some redundancy built in for safety. And don't forget to prepare the staff very carefully before you roll out a change to their workflow. Lastly, thinking about measurvention, don't get started until you're already doing really well. Distribute the task to multiple workers, but not everyone, because then it's too hard to educate them all. And if you can, try to integrate it into an existing workflow. That will save people a bunch of time, make them feel like it's not a new task. Insist on good safety culture and communication, so no grumpy doctors. Pilot the intervention before launching hospital-wide, and try to support the work with easy-to-use reports or dashboards so that it's easier. So that brings us to the questions and discussion. First, Kim, do you want to tell me if there's any questions that have been in the chat box?
Sure. While we're waiting for any questions to be typed into the chat box, or if you would like to unmute your line by pressing 4*, and you can ask your question then too, and I encourage you to please type in any questions you have here. First of all, I just want to say thank you. This is great, and I really do appreciate the overview of just the basic quality improvement strategies here too, including the one that I think a lot of us don't think of when we're trying to take our outcomes to the next level of reliability. And there's the one side of starting with quality improvement when we are just starting out on a project, and but taking something like measurvention, which is a true high reliability technique, unless we're already doing some of the work well, it is just going to be frustrating. But I think this is a really good example of a way to bring reliability into our VTE practices. And I have seen a lot of hospitals now starting to implement this, and I would be curious to find out if there are any hospitals that are on the line right now that have already implemented something like this, or have maybe included some of the questions. If maybe you're not quite at the measurevention stage, but are you including some of, a review or some questions of appropriate VTE prophylaxis for your patients? I know there are a lot of us that have routine safety rounds or safety huddles a couple of times a day in a 24-hour shift. Is this something that you could include in there? And I think this is definitely something that could become part of our standard work, so that we're not just adding another project to the ever expanding list, just like you said. I don't see questions being typed in yet, but I did want to ask you a question for those hospitals that might not want to speak up about it yet. I know that there are still some hospitals that are having the nursing staff do the risk assessment for, prior to physicians ordering any sort of VTE prophylaxis. What kind of advice do you have for those hospitals that are trying to implement the physician-based assessment of risk and getting away from the nursing side? Do you have any pearls of wisdom for those hospitals?
Yeah, so excellent point. I think a lot of physician groups sometimes will push back against a new project like this, and they'll say, we don't want to do this. If the nurse fills out the form, then we can act on that, and it'll save us time. There's a couple problems with it, though. The first thing is that a lot of times the doctor's notes are not complete, or they're written in a way that the nurse doesn't have access to them, or doesn't understand what the physician's abbreviations are, or all the details of the patient. And so the nurses simply don't have all the information they need to make the decision about whether the person needs prophylaxis or not. So if they're using a point scoring system, the physicians say, I don't want to do that, I'll pass it on to the nurses. But you get erroneous information, and then you just sort of garbage in, garbage out. It's not fair to the nurses because they don't have as much information about what's happening as the patient does. So that's the big problem with it, and that's why we recommend doctors do it. What you will frequently hear is that doctors say, I don't have time to do a VTE risk assessment, and that's the biggest thing that people are concerned about. So what I tell those groups is that we have in several hundred hospitals use this bucket model, and you can do a risk assessment in less than a second. It really does not take any more time than ordering the medications would anyway. So, for example, if I admit a patient, that comes to my service with a hip fracture, I know they're high risk. There's no work to be done. Like, I don't have to push that off to the nurse. Like, I just order a high-risk, medication, and I have to think about when it's going to be held in preparation for the procedure. Pretty easy. I know my patients, most of my medical patients are, medically ill and not getting out of bed initially or something like that. So most of them need prophylaxis too. They're medium-risk patients. And I know that if I have an OBS patient who's not that sick, well, that's a low-risk patient. It literally takes me less than a second to make those decisions. And for the physicians to push back because they don't have time to do that doesn't really make any sense. That doesn't mean the physicians are going to be reasonable or good-natured about this. Sometimes they really just say, like, I don't want to be involved in this. And then you have to appeal to things like, the science, to the responsibility to patient safety. It helps to tell a story about patient harm. Try to get them on the same side and say, how would you feel if this happened to someone that you admitted or to someone that, like if your spouse was here and they had a VTE because nobody did a risk assessment, how would you feel about that? Would it be worth it for you and your health if you were admitted to the hospital for a doctor to spend less than 2 seconds thinking about your VTE risk? I probably would say yes. So that gets into the whole like winning over physicians thing, but there isn't any good reason for them to resist because this actually is quite easy to do. And that's one of the big advantages of the bucket model over the point scoring systems.
Perfect. And you also then just touched on another key point that I wanted to highlight again that you'd made about when we're designing these programs too, or these processes, that all of our stakeholders are involved from the beginning of the design here. So that means those different physician groups, and not to, pile on physicians, that's not at all what I mean, but, to make sure that everyone that is going to have an opinion and is going to be involved in this is part of that decision making at the beginning, especially when it comes to this topic area when there definitely are some differences of opinion on what makes an appropriate method of prophylaxis for different types of patient populations too. So I appreciate you making that point there too. So we are coming right to the very end of the hour here, and I just want to thank you so much. I know that we have a lot of hospitals that have requested that making sure they're going to have the recording of this because I believe this is going to be rebroadcast in many of our organizations here too. So I really just appreciate you all taking the time to join us today. And for Dr. Jenkins, thank you so much for sharing your experience, your expertise with us. I think I have a couple of, let me get to the very end here. There's a few slides that you can go through and can see on your own here, but at the very end here, I did want to make sure that you know that there are a couple of other resources too. My email and Shweta's email here, in case there are questions that come up that you would like for us to ask of Dr. Jenkins, we'll be happy to pass your questions along. There is also a VTE change package that is available through our HEN that you can certainly download. Has lots of information that you will notice Dr. Jenkins and Dr. Greg Maynard's names throughout, because they have certainly been resourced heavily here. We want to use your expertise as much as possible. So would encourage you to download that VTE change package too, in addition to the ARC and the other resources that were mentioned during the broadcast here. So thank you so much, everyone. It's the top of the hour. So please take this information and go back and make improvements. Thank you.
Hey, thanks so much for having me.